talk about how we go to a quality collaborative. And the next thing is, it really takes a partnership of a variety of sectors. And John and I are an example of some of those sectors that need to get together if a state's going to pull together for quality collaborative. First, you definitely have to have clinical care. By clinical care, we're talking about doctors and nurses and health administrators and everyone involved in provision of clinical care, and everyone needs to be on board. The clinical care aspects need to sort of direct how the initiative is going. They're going to be the primary people to help develop the education material and assure it's provided. They need to have direct input into the guidelines and policies. In fact, most find that the on-site units need to be actually responsible for the management of their own quality improvement program if they're going to improve, because they have to have ownership. And they need to be able to provide the data, because we've discovered without the data, people think they're doing really well. And when they see the data, they learn how well they're doing. The other part of that triangle is healthcare systems and plans need to be on board. We talked about healthcare executives within a hospital. As more of our hospitals are networked, the role that a network has to play becomes more important, because no one hospital makes a decision totally on their own. In plans, these leaders need to actually have leadership for quality improvement. And they need to tangibly give overt support, as John said, to what needs to take place in quality improvement. Because if they do not value it, then the administration is not behind it, the quality initiatives fall short. They need to create rewards for those who are doing well. They need to establish requirements for how people need to perform, and they need to put forward resources. As John said, this is a value-added initiative, but somebody has to put that money in place to actually have the initiative take place for that value add to come back in return. The third component that we want to say in this collaborative that's really important is public health needs to be actively engaged in support. Public health has a population focus. It's not only important about improving the quality in one doctor or in one hospital or in one system. As John said, we need to get everybody on board. So we need to have a group who's accountable for everybody so that all women benefit from the quality of care that need to be improved. And more important, we need to know where the issues are on a population basis so the hospitals and systems know where they need to be targeting and focusing their effort. Public health is accountable to the public and needs to add that accountability pieces to the healthcare providers of what needs to be there. Frequently, the health department needs authority, or the Medicaid agency needs authority to assure that some of these things take place. To assure a population-based focus, there needs to be public resources made available, not full, but partially, to make sure that this takes place. And a lot of the data sets now that we're talking about, especially as we try to look across the state, we need to create those measures. And it really takes those three parts together. And in that, that's where the Florida Perinatal Quality Collaborative came to existence. That's where many of the state qualities come together, because the three parts of the triangle need somebody who's going to sort of coordinate all those partners and all those people in that effort. And then in Florida, it took the March of Dimes stepping up. The March of Dimes pulled everybody together politically so that no one person was the in-charge group. We put all the players together to define what needed to happen. How did we relate? How did we operate? Where was it stationed? And without the March of Dimes, we wouldn't be where we are. So it took all those pieces.